Let's see an NCLEX RN video based on care for patients with stomach disorders. Which patient statement indicates effective teaching related to acute gastritis? I will eat a diet rich in milk and cream to decrease the secretion of hydrochloric acid. I need to avoid using aspirin or non-steroidal medications for routine pain relief. I will need to return for yearly upper endoscopy examinations. I will need to fully cook all meat, poultry and egg products. The most common contributing factor to acute gastritis is the disruption of the integrity of the gastric lining by gastric irritants such as aspirin or non-steroidal anti-inflammatory drugs. A period of gastric rest followed by a slow progression to regular dietary intake is advised in these patients. So here the best statement is I need to avoid using aspirin or non-steroidal medications for routine pain relief. The nurse identifies which nursing diagnosis has the highest priority for the patient admitted with peptic ulcer disease and possible perforation. Acute pain, ineffective health maintenance, nausea, impaired tissue integrity related to the gastrointestinal system. A peptic ulcer is an interruption of the integrity of the gastric lining. Perforation is the most dangerous complication of this process. So, in this peptic ulcer disease, there will be impaired tissue integrity of the gastrointestinal tract. Inflammation, infection and possibly shock can also occur. Following a partial gastrectomy for gastric cancer, a patient complains of nausea, abdominal pain and cramping and also diarrhea after eating. Recognizing the manifestations of dumping syndrome, what should the nurse recommend? Fasting for a period of 6 to 12 hours before meals, decreasing the protein content of meals, decreasing the amount of fluid taken at meals and avoiding high carbohydrate food, including fluids such as fruit nectars, a diet rich in carbohydrates to maintain blood glucose levels. Dumping syndrome. It is a term that refers to a constellation of vasomotor symptoms that occurs after, especially following a gastrectomy. Frequent small meals with solid food or liquids, not both, are effective in controlling the hyperosmolar problem of dumping syndrome. The nurse should instruct the patient to decrease the amount of fluid at mealtime and also to avoid high carbohydrate food, including fluids such as fruit nectars. And also the nurse should instruct to assume a low Fowler's position during meals and also to lie down for 30 minutes after eating to delay gastric emptying. So here the nurse should recommend decreasing the amount of fluid taken at meals and avoiding high carbohydrate foods including fluids such as fruit nectars. Which nursing diagnosis is most appropriate for a patient admitted for acute GI bleed related to acute gastritis? Imbalanced nutrition less than body requirements, risk for deficient fluid volume, acute pain, deficient knowledge. Gastritis and peptic ulcer, they are the most common cause of upper GI tract bleeding. Hemorrhage is the most common complication and may be manifested by hematemesis or melena. Large quantities of blood may be lost quickly, so immediate correction of blood loss may be required to prevent hemorrhagic shock. Defining the characteristics of fluid volume deficit, it is related to gastrointestinal bleeding include hypotension, tachycardia, decreased skin turgor, weakness, decreased urinary output, pallor and diaphoresis. So here the best nursing diagnosis is risk for deficient fluid volume. The healthcare provider prescribes a combination of antibiotics for a patient with peptic ulcer. The patient asks you why these types of medications are being given. What is the nurse's best response? It will increase mucus production in your stomach. The combination of antibiotics will help to rid the stomach of H. pylori bacteria. This medication will help buffer the gastric acid in your stomach. It is used only as a prophylactic to prevent colonization of bacteria in the stomach. H. pylori infections can remain active for life if not treated appropriately. Elimination of this organism occurs for allowing the ulcers to heal more rapidly and remain in the remission stage for longer. 2 or more antibiotics are given continuously or concurrently to increase the effectiveness of the therapy and to lower the potential for bacterial resistance. The antibiotics are also combined with proton pump inhibitors or an H2 receptor antagonist. So here the nurse need to tell the combination of antibiotics will help to rid the stomach of H. pylori bacteria. The nurse is screening patient for the risk of developing acute gastritis. The nurse should consider which patient at greater risk. A 25-year-old woman who has a vegan diet, a 32-year-old man who takes ibuprofen daily, a 77-year-old man who smokes, an 80-year-old woman who takes low-dose aspirin daily for atrial fibrillation. Frequent ingestion of non-steroidal anti-inflammatory drugs such as indomethacin or ibuprofen is associated with acute gastritis. Non-steroidal anti-inflammatory drugs inhibit the prostaglandin synthesis and diffuse rapidly into the gastric mucosa, causing mucosal injury. So here the patient at greatest risk is 32-year-old man who takes ibuprofen daily. The nurse recognizes that the treatment of H. pylori includes which medications? Proton pump inhibitors, antiemetics, antibiotics, non-steroidal anti-inflammatory drugs, antacids. So there are various treatment regimes for H. pylori eradication, and the most important ones include the combination of proton pump inhibitors with 2 antibiotics for 7 to 14 days. H. pylori release a toxin that promotes the mucosal inflammation and ulceration, stimulating the release of cytokines and other mediators of inflammation that contribute to mucosal damage. Damage to gastroduodenal mucosa allows for decreased resistance to bacteria, and thus infection from H. pylori bacteria can occur. The nurse recognizes which gastric disorder is a complication of inadequate mucosal perfusion secondary to intense physiological stress. Erosive gastritis, chronic gastritis, duodenal ulcers, esophageal reflux. Erosive or stress-induced gastritis is a severe form of acute gastritis that is a complication of conditions such as shock, severe trauma, or major surgery, most likely due to inadequate gastric mucosal blood flow during periods of intense physiologic stress. Adequate mucosal blood flow is important to maintain the mucosal barrier and to buffer any back diffused hydrogen ions. When blood flow is inadequate, these processes fail and mucosal breakdown occurs. The nurse correlates which clinical manifestation to the pathophysiology of a gastric ulcer. Pernicious anemia, constipation, acute epigastric pain after eating, hypertension. With a gastric ulcer, pain is triggered or worsened by eating. When there is increased acid content of the stomach, which erodes the lesion and stimulates the exposed nerve endings. So here acute epigastric pain after eating is a clinical manifestation to the pathophysiology of gastric ulcer. Pernicious anemia occurs with chronic gastritis. Constipation and hypertension, they are not manifestations of gastric ulcers. Nurse is caring for a 33-year-old woman who has been taking aspirin for back pain and has experienced a sudden episode of tachycardia and feeling faint. She also vomited coffee ground at emesis and passed her tarry stool. but has no complaints of pain or heartburn. The patient wants to know why there are no signs of pain as a warning signal prior to sudden bleeding. What is the nurse's best response? Pain is the most common sign of NSAID-induced gastric injury, so the patient must have a high pain tolerance. NSAIDs cause damage to the epithelial cells which inhibit the enteric nervous system response to GI tract. NSAID-induced gastric injury often is without symptoms, and life-threatening complications such as GI bleeding can occur without warning. NSAIDs have anti-inflammatory and analgesic effects, preventing the patient from feeling any pain as a warning sign. Serious adverse GI effects like bleeding, ulceration, perforation can occur at any time in patients receiving NSAID therapy, and such effects may not be preceded by warning signs or symptoms. Only 1 in 5 patients who develop a serious upper GI adverse event while receiving NSAID therapy is symptomatic. A 67-year-old male is suspected of having a peptic ulcer. The nurse monitors for a decrease in which diagnostic value with GI hemorrhage in the patient. Reticulocyte count, hematocrit, prothrombin time, IgG antibodies to H. pylori. The hematocrit reflects acute magnitude of blood loss after a period of 2 to 24 hours depending on bleeding rate. Serial hematocrit assessment can follow a patient's course. Other hemodynamic assessments such as complete blood count, coagulation test, and electrolytes, that is BUN and creatinine, should also be included to assess the fluid volume deficit. The nurse monitors for which clinical manifestation in the patient diagnosed with a duodenal ulcer. Intermittent abdominal pain, which is relieved after eating and taking antacid but becomes worse at night. Nausea and vomiting, right upper quadrant tenderness and is positive for occult blood and stool, complaints of heartburn or regurgitation and vomiting, bloating and flatulence. So in a patient with duodenal ulcer, there will be intermittent abdominal pain which is relieved after eating and taking antacid but becomes worse at night. And there will be right upper quadrant tenderness and is positive for occult blood and stool. There will be complaints of heartburn or regurgitation and vomiting in patients with duodenal ulcer. The nurse incorporates which information in the teaching plan for a patient diagnosed with duodenal ulcer. You will probably have increased pain after eating. Smoking cigarettes can make the peptic ulcer disease worse. Antacids are not usually effective for the pain. Eating bland food will aid in healing. Cigarette smoking may predispose people to peptic ulcer disease including duodenal ulcers and may interact with H. pylori and NSAIDs to increase the mucosal injury. Smoking also impairs ulcer healing and increases ulcer recurrence. Burning epigastric pain is aggravated by fasting and improved with food or antacids with duodenal ulcers. There is no evidence that bland foods impact the peptic ulcer disease. So Mr. Taylor, a 37-year-old, over the last several months she has had increased episodes of burning sensation near the midline in the epigastrium and back. Her pain has been alleviated after eating. Mrs. Taylor has had recent episodes of pain, waking her up few nights a week. Taylor schedules a visit to her advanced practice registered nurse. On the basis of her history, the provider orders an endoscopy. The provider explains that the endoscopy allows visualization of the esophageal, gastric and duodenal mucosal linings, as well as allowing tissue samples to be obtained for biopsy during the procedure. The endoscopy reveals several peptic ulcers. A tissue sample is taken from Mrs. Taylor's stomach lining. The tissue sample is positive for H. pylori, a gram-negative bacterium that infects the stomach. Mrs. Taylor's treatment of peptic ulcers and infection includes 2 antibiotics, a proton pump inhibitor, and bismuth salts. She is instructed to take the entire course of her medication and to follow up with the internist in 6 months for a repeated endoscopy. The provider explains that failure to be compliant with the medication regime may cause antibiotic resistance and persistent infection. The nurse is monitoring Mrs. Taylor, who has been diagnosed with peptic ulcer, which assessment finding most likely indicates perforation of the ulcer. Bradycardia, numbness in the legs, sudden and severe epigastric pain, nausea and vomiting. Perforation of an ulcer is a surgical emergency and is characterized by sudden, sharp and intolerant severe pain beginning in the mid-epigastric area and spreading over the abdomen, which becomes rigid and broad-like. Nausea and vomiting may occur. Tachycardia may occur as hypovolemic shock develops. Numbness in the legs is not an associated finding. So, the most likely indication of the perforation is sudden and severe epigastric pain. Mrs. Taylor is scheduled for a vagotomy and asks the nurse about the purpose of this procedure, which response by the nurse is most accurate. Diminishes stress reactions, heals the gastric mucosa, reduces the stimulus to acid secretions, decreases food absorption in the stomach. A vagotomy or cutting of the vagus nerve is done to eliminate the parasympathetic stimulation of the gastric secretion. So the other three options are incorrect descriptions of a vagotomy here. The nurse is monitoring for early clinical manifestation of dumping syndrome, which findings are consistent with this complication. Sweating and pallor, bradycardia and indigestion, double vision and chest pain, abdominal cramping and pain. Early manifestations of dumping syndrome occurs 5 to 30 minutes after eating. Symptoms include vertigo, tachycardia, syncope, sweating, pallor, palpitations, and the desire to lie down. So here, sweating and pallor. The nurse is reviewing the medication order regarding Mrs. Taylor's peptic ulcer disease. Which medication, if noted on the patient's record, will the nurse question? Rabeprazole sodium, furosemide, indomethacin, propranolol hydrochloride. Indomethacin is a non-steroidal anti-inflammatory drug and can cause ulceration of the esophagus, stomach or small intestine. Indomethacin is contraindicated in a patient with gastrointestinal disorders. Furosemide is a loop diuretic. Rabeprazole sodium is a proton pump inhibitor used in treating gastrointestinal disorders such as GERD and duodenal ulcers. Propranolol is a beta-adrenergic blocker. Furosemide and propranolol are not contraindicated in patients with gastric disorders. The healthcare provider has ordered a blood test for H. pylori. How does a nurse prepare the patient for this diagnostic test? Instructing the patient not to consume food or liquid after midnight, giving an oral suspension of glucose 1 hour before the test, explaining that a small dose of radioactive isotope will be used, telling the patient that no special preparation is needed. No special preparation is needed for the blood test for H. pylori. Instructing the patient not to consume food or liquid after midnight is incorrect because the patient is not NPO before the test. If you see the second option, giving an oral suspension of glucose 1 hour before the test, it's incorrect because glucose is not administered before the test. And the third one is incorrect because it refers to the preparation of the breath test. That is what explaining that a small dose of radioactive isotope will be used. I hope you understood this video. Thank you so much for watching.